Hi, it's Dr. Brower, and I'm going to give you an introduction to mini dental implants today. So this board here is something that I have in all my courses, and it has a lot of the different information and things that I get asked all the time. And I'm going to go through the board with you just briefly and give you an idea of what mini implants are, conventional implants, and the differences between the two. So mini implants, by their definition, are an implant smaller than 3 millimeters in diameter. So that means that for a code, it's a D6013, and if it's a 3 millimeter, it's a D6010. Okay. Mini implants are always one piece, meaning that the abutment and the screw are part of it. They can have an oval or a crown bridge head on it. There's also a convertible abutment that you can buy that's made out of titanium. Interlock sells them among other companies, and that can be cemented on, and then you can impression that for a regular crown. Zest has a system where they have mini implants and they're externally threaded, and then you will take and thread the locator attachment on it, which is the same as what you use for a conventional size implant locator. That is much wider than the oval housing. It's about 8 millimeters wide, and the conventional mini implant housings are somewhere between 3 and 4 millimeters wide. So when you look at implants that are larger, over here the conventionals, you can have single stage or two stage. So the single stage means that it's a one-piece implant, just like we have over here, and it can be placed with the abutment sticking out. Or single stage can also mean if it's immediately loaded, meaning that you're going to place it and place an abutment into it after that. If you have an area where it's not particularly well healed or you're unsure how well it's going to do, you put a healing screw to cover your implant, and all the manufacturers come with that. It does not stick up very high off the top of the implant. If you feel pretty confident that you have really good stability, then you can do the abutment, and that's going to be right out of the tissue, like so. And you can place that, and there's even implants that are approved to have the crown placed very, very quickly if they're immediate load, immediate placement. So the combination of the two is what is traditional, old school, conventional implant dentistry. And that's where you place the implant, and then you place a healing abutment that's going to stick through the tissue, usually 0.5 millimeter to a millimeter. That is going to create a tissue profile or emergence profile that's going to emerge like a real tooth coming out of the gums, and that is always the nicest looking type of restoration. So again, here's the healing screw. You place the implant just at or below the bone level. The manufacturers are always a little bit different on that, and you just want to follow their guidelines. If you're going to do mini implants in general, you're going to be assuming that you have longer bone that's available to you, or hardly any bone at all, one or the other. And this chart right here will show you the approximate sizes of the mini implants that I prefer. And if I were going to buy 100 of them, this tells you I would buy 10 of this and 10 of this and 50% of that. So this is a 2 millimeter collared implant, 2 millimeter non-collared implant, and these are the sizes where it goes from 10, 13, 15, and 17. So you can see that I really don't think you should buy a 2 millimeter, 17 millimeter long implant. It doesn't seem to fit very well in my usage of them after placing many thousands of them. So the probably most standard sizes are the 2.5 by 13. It tends to be a really common one. And then my little mark up here that's kind of goes a little further is people ask me, when would I use the longer implants? In the lower anterior mandible, typically if you're doing immediate extraction, you're going to be using at least 15 to 17. And if you have the bone and stability in most of the other locations, you'd like to use a 15 millimeter collared and non-collared implant. If they're non-collared, that means that you have 15 millimeters in the bone. In some cases, or 13 millimeters if it's an intralock, which is always smaller. The collar itself, the first one's about 2 millimeters and the second one's 2. So Park Dental Research sells a collared implant. What that means is that this area right here goes through the tissue. And this area right here is in the bone. So they have a patent on the technology and say that there is some labyrinthian grooves here that stop bacteria from transmitting down. I can't say that, the patent is worth a lot for the labyrinthian grooves, but I can tell you that I personally don't have problems with a lot of bacterial infections around any of my minis. So oral hygiene is the most important thing with your patients if they're going to get an infection. So when I go down to a sloppy fit versus a precision fit, what I talk about there is a ridge lap contic, that's the sloppy fit, meaning that the O-ball for a crown is just filled in with cement, so everywhere right here is just cement. And that's going to lock into the undercut, and that's been done for a long time, and it does work. I personally prefer, if I can, to have something that's a little more precision fit, so I like to have the crowns made with the square all the way in like that, and then it goes all the way up. So I have a little bit of room here, but the square itself gives a very tight anti-rotational fit, and it's very precision. This is not even tight on the square. From the bottom view, it just looks like a smaller circle, whereas I like to have that nice precision square. So this gives you an emergence profile like it's coming out of the gums. I think that's a little more important in like the lateral incisors or any cosmetic area. This one, just like having a supragingival margin for a molar, works pretty well in most cases. I do not recommend mini implants except for exceptional circumstances in the posterior maxilla when you have soft bone. You can place them and get bi or tricortical stabilization by tilting them underneath. Some patients are just too ill, or the success rate of the sinus could be so poor that this is the only option that you can offer them to add some additional stability. Many of these patients aren't very healthy, and you may not get 15, 20 years success, but you may have a lifetime success because of the health of these patients, and that's what I look at when I'm doing these kinds of things that are a little more heroic than I would normally like. So, going back to this, mini implants are always tapered. There's different types of tapers. In the conventional implants, you have some that are tapered, some that are less tapered. Short, wide implants that go into the sinus are typically not tapered, and that's because you want the maximum amount of bone, because the bone is up to usually about 12 to 15 millimeters wide in the posterior sinus there. So you have width, but you don't have a lot of height. I have placed mini implants and had them engage right here and had success, and I've also had them engage into the lingual wall under there and had success. So many things can be done, but ideally you really need to have a CT if you're going to start to do some of these more advanced treatments. Well, I hope that's an introduction to mini implants. I know it didn't go into a lot of the crown and bridge scenarios, but it should give you a good idea of where you can get started. With removable, the concept is always 4 minimum on the lower, 6 on the top. I usually like to add 2 more to that if I intend to trim that denture back at all or give the patient a good chance of long-term stability. Anyway, thank you very much.